This is just a slide on Community Care of North Carolina. In the event that I know there are people here who are not familiar with the program, the beauty of it is there are 14 networks. The networks are administered by the state, so state employees are involved. There are physician boards that direct the program in each network, and the network receives a budget. And the most important thing that we do in our large rural network with our administrative money is we put care coordinators in the communities. So our practice has over 13,000 Medicaid patients. We have 3 care coordinators in our main office, and they're just worth their weight in gold. And our Smart Start, Head Start, Health Department, Mental Health, everybody plays, and these care coordinators make sure it works. We're saving the state over $150 million a year because we all focus on cost centers such as emergency department utilization, hospitalization, expensive pharmaceuticals, but then we're also doing a pretty significant quality improvement piece so that the state can share in some outcomes that are other than financial. Care coordination by insurance companies, on the other hand, is a 1-800 number, which is not very helpful to most of the families that you and I take care of every day. So I would tender the North Carolina Community Care of North Carolina model to all of you as something to look at as we try to integrate what is good about health care reform with what is really good for children and families. Now, I want to bring your attention to issues that are somewhat academic, but you are more in the middle of that than most pediatricians. I have gotten into the middle of that because probably of the community I serve. So I want you to understand that most pediatricians need a little help getting there. There's going to be a full day tomorrow for pediatricians at this conference, which I would applaud Steve Shore, the executive director of the North Carolina chapter, for putting together, and for Smart Start for partnering in a big way with pediatricians. And I think you'll see a focus on these issues. But we know that the milieu within which children are born and experience early childhood has tremendous bearing on where they go later on. And the ACE study, which is documented through the CDC, and that's your website, which you've probably read about before. So if children are grown in or born into families where there's domestic violence, where there's substance abuse, just basic family dysfunctionality that you and I see so often, then we can predict they're not going to do well now or in the future, and we can try to intervene. The problems that we need to be picking up on are postpartum depression, and I think you can do this as well as I can. And this may involve 8 to 20% of women, and we know the children are going to suffer when the families are suffering. There are very easy to do psychosocial screenings. We're trying to incorporate the Edinburgh postnatal depression scale into our practice as we speak. And then these parents can be referred once a diagnosis is made. Again, we wouldn't expect you to make a formal diagnostic and statistical manual diagnosis like a doctor would, but if you've got bad vibes, calling an obstetrician or calling a pediatrician or calling a mental health professional is certainly something within your scope of practice, and I think our responsibility. And we know these women do much better when they receive a combination of behavioral cognitive therapy and appropriate medication. And then, of course, they probably need extra attention for family support. Reactive attachment disorder is rampant in our population. We received a grant recently for our practice to go into an elementary school and look at the mental health needs of K to second grade children, and you would be blown away at the psychopathology in this one school where one of our nurse practitioners did a marvelous job fleshing things out and organizing the staff. But basically, as soon as a baby is born, if a loving adult, especially the mother, is not holding that child with their face 14 inches away from the baby's face, as many minutes a day that the child is awake, talking to that baby, so there's just constant attachment between baby and mother, baby and father, baby and grandparent, aunt, uncle, whatever it takes, then that child's right brain is not going to develop properly, and we're going to be picking up the pieces for the rest of that child's life. And you and I see families every day where attachment is a huge issue. And again, you're not going to make the formal diagnosis, but if you suspect that attachment is going awry, I think it's our collective community responsibility to involve family, mental health professionals, pediatricians, whomever we can involve to try to bring as much attention as early as possible to this very serious mental health disorder. And I'm not going to belabor all these slides with you. In our practice, just to give you an idea of where the pediatrician may help you, I was first recruited into this. These were my teachers. The nurse for Head Start called me right after I started my practice and said, "We get some kids with heart murmurs and we need somebody to help us. And would you be willing to work these kids up?" And I said, "Well, I'm not a cardiologist." She says, "I know, but we just would, they can't get out of town. They can't go see a cardiologist. You're the best we got." I said, okay. Send them on. So I was doing EKGs and chest x-rays and listened to them and hemming and hawing about whether I needed to send them to, Greenville or Chapel Hill or Duke or Raleigh or wherever where there was a cardiologist. And lo and behold, it didn't take long before the pediatric cardiologist at Brody School of Medicine in Greenville, 39 miles from my door, but pretty far piece for a lot of my patients, decided, oh yeah, we could come to Goldsboro and set up a clinic in your hospital. And our hospital gave them the echocardiogram equipment, and now we have 2 half days a month where the cardiologist comes in and takes care of the kids. And so this was good for Head Start, and it was good for families, and good for these children, needless to say. With adolescent pregnancy, when I was on the school board, we realized we had about 50 pregnancies a year in the early 80s in this one high school. And our school board decided, well, the best thing we could do is hire a health educator away from the health department and put her in the high school. And since I was the only doctor on the board, I got to be her supervisor. And lo and behold, even though there were laws to prevent us from doing human sexuality education in the high school, if you read those laws carefully, you can talk about abstinence first at every encounter, and you can answer any question you want to answer. And so this young health educator working with me and an associate superintendent dropped the pregnancy rate by 50% in about a year, just by becoming a friend to the children. And again, I had no idea what was going to happen when our school board actually led us down this path, but that partnership of the schools and the health department and the private practice of pediatrics just worked wonderfully, because if she detected a medical issue, I would see the child in the office or find someone to see the child, or the health department would see the child. But without that outreach, nothing would have happened.